Ethical Perspectives on the News is produced by the Interreligious Council of Lynn County, which is solely responsible for its content. The views and opinions expressed on this program do not necessarily reflect those of the staff and management of KCRG TV9.
Good day. Thank you for joining us today on Ethical Perspectives in the News. My name is Leon Tabak, and our topic today is mental health and privacy. I have with me, to help us in this discussion, Peggy Loveless, Leslie Carpenter, and Dr. Jess Fiedorowicz. Peggy is a mental health first aid trainer. Leslie is a physical trainer who has had some experience in her family with these issues. And Dr. Fiedorowicz is a professor of psychiatry at the University of Iowa. So why don't you each tell me a little bit about why you chose to join us here, a little bit about your background, and then we'll get into our discussion here. Peggy?
Okay. Yes, I have a daughter who has paranoid schizophrenia, and she was finally diagnosed with that when she was around 22. And we've gone through trial after trial and just all kinds of tribulations and whatnot. Then I started teaching because I felt like there just weren't enough people educated about mental health. So I've evolved into teaching mental health first aid, which is a first aid course for mental health, just what it says. So just like CPR and whatnot, this is for people who would like to know what to do if they see someone in a crisis or someone having problems.
So Leslie, you're also a member of our community who's been affected by these by mental health challenges. Mm-hmm. Can you tell us a little bit about what brings you to us today?
Sure. I am a physical therapist, but over the past 10 years, our son has been ill. He has now had a mental illness that has evolved into a schizoaffective disorder, which is a combination of schizophrenia and bipolar disorder. And over the course of the past 8 years, especially, he's been in and out of the hospital about 15 times. We have had several times where it's been an issue being able to communicate effectively with the mental health care team because he at times would not sign a release for us to be able to do so. But we have over the course of time figured out how to work around that when that's been the case and to work within it as best we can. And so I'd like to be able to advocate and teach other family members who might be earlier in the process how to make it still work out even if your loved one won't allow you to actively interact.
And Dr. Fiedorowicz, Jess, I think that you have experience both in research and in treatment of patients. Is that the case?
Yeah, that's right.
Can you tell us a little bit about your background?
Yeah, so I'm a physician scientist at the University of Iowa, and I went to medical school not planning on going into psychiatry, but being struck by the impact that the conditions had on the patients and their families, and seeing how difficult it was for them to navigate both the mental health system as well as the broader health system. And my research sort of addresses that. So my research is focused on the excess mortality associated with these conditions, which is not just limited to suicide, but also vascular disease. And so I'm very interested in the intersection between sort of mind and body and how these conditions can affect physical health and how navigating the system can be important to maintaining health.
So I want to say a little bit about why I proposed this topic to our producers. I was struck at the end of the fall semester when I was sitting with a group of other professors, and one of these professors talked about students who had dropped the course at the end of the term and broke that group into two groups, those who had dropped because of academic reasons and those who had dropped of mental health reasons. And there was a conversation that went around the table, people nodding and saying that and counting their own students in this way. And so there's some sense that either we're diagnosing more, or we're seeing more, or there's a greater prevalence. Is this the case? Do we see a greater prevalence of mental illness, or is it just a case of more diagnosis? Or who would like to help us explore that?
All of us could probably.
Okay. Sure.
Just to start, 1/2 of all mental illnesses start by age of 13. 3/4 by age 24. So you're seeing your students in college and having that happen, that's the age a lot of times where these illnesses will present. Okay. So, and I think we're getting more aware. I don't know if it's happening more, but I think the awareness finally might be increasing. Leslie?
I would concur. I'm going to let you, I'm going to defer.
Sure. I mean, I think that my sentiments would reflect that. And so these conditions are common. And so it's not unusual for someone to have someone with a mental illness in their class. These conditions affect many Americans, many people throughout the world. There's some controversy about whether some of these conditions are increasing in prevalence or becoming more common or not.
Right.
And I think the general consensus is that these conditions are just common. They're present throughout the world. They don't discriminate. So they're seen it can be seen in any family, in any community. And if we're identifying them more often, it's just because we're doing a better job of recognizing them and identifying folks.
So the second reason that prompted me to suggest this topic was that several colleagues and neighbors spoke with me frankly about mental illness in their families. One who was affected directly himself, another less directly. And this made an impression upon me because it's common in small talk if I meet you, if we're working together and I meet you in the morning and I know you twisted your ankle last week, I'll ask you about that. I know you had a little cold, I ask you if you're recovering. I'm not asking you if you're mentally ill, okay? And so there's a different way we talk about these things, and I want to hear a little bit about how we should be talking about that. And again, with physical illness, we cover the whole spectrum. We use the word physical illness to mean a little cold or a little hay fever, and we also use it to mean illnesses that are life-threatening. So tell me about how we should be talking about mental illness. You skipped the last time, so maybe Leslie, you can help us out here.
Okay, so you bring up a very good point. This is not something that's easy to discuss on an everyday basis. In my world as a PT, I see patients 3 times a week to get them through after a total knee replacement. They will ask me all sorts of questions about my family, and initially, I did a lot of avoidance. I would talk about my daughter till the cows came home. But over the course of time, as you start to be able to handle it better, it becomes easier to say, well, actually my son is not well, he's disabled, and he has a mental illness. It's not easy to say, and it's certainly not easy to say in a professional setting, when my care should be focused all about them. But people will push and ask a little bit more. It's not like saying my son has cancer. There is no sympathy there. There is not the same type of ability to even discuss it. For probably the first 5 years, I couldn't discuss it without crying, so I simply avoided and steered the conversation away. But we should be able to say, well, actually my son has a schizoaffective disorder, but I'd rather spend our time talking about this today. And that's how I defer it and try to move on. But you're right, we don't talk about it, and we should. It should be common, and it should be something where people could say, yeah, can I bring you a casserole? How could I help you?
Right.
Instead, it gets pushed aside.
The people come to you, Peggy, have they already accepted this idea of mental illness, or are they coming to you to ask where they're at?
It varies. Generally, with the mental health first aid class, I'm teaching a lot of people who are actually in the field, who are social workers and mental health workers, as well as I'd like to have more general public, people who deal with the public, because this is something everyone wants to know about and needs to know about, so we can open up the discussions. And so someone could say, oh, you seem a little depressed today. Are you doing okay? Why not? And are you feeling okay? And, a person can talk about it and not feel embarrassed about it. So
a particular question I have, Jess, again, is we want to talk about how the law treats this and what we think the law ought to say about respect for the autonomy of the patient, respect for the privacy of the patient, and on the other hand, the understanding that the family may play an important role in helping these young people. So I'm particularly thinking about young people who may be still dependent upon parents. They might be in late adolescence or early adulthood, and they may not be ready to let you confide to their family about what's happening. And then parents find themselves in a difficult situation. They want to provide care, but they don't know what's happening. Is this a situation?
Or are providing care and don't know what's happening.
Right.
Yeah. No, I think it's a common situation, and I think it's very important for clinicians to take every advantage of the opportunity to work with families who are caring for their patients. It's in the best interest of your patient or client to involve and engage the family. Oftentimes family have information, perspectives, observations that you might miss in your clinic setting or within a hospital setting, and so I think it's very important to involve families. One caveat that I think I want to add as well is that sometimes patients may feel uncomfortable with you contacting their families or ask you not to contact them. Right. But I think the question can be framed in ways that facilitate it and make it more likely to happen. So we can say, is it okay if we talk to your mom, is one way to say it. But another way to say it is, it's a routine part of care. It's important for us to get information from people that really know you well. Mm-hmm. And this is something that we'd like to do. And who knows you best and who can we contact? And I think that gets different results than, do we have your permission to talk with your mom? And the other thing I think is it's not a static thing. And so oftentimes we're working with people not just at a single point in time, but if they're in the hospital, we may see them several times each day or at least each day. If they're in clinic, we may see them repeatedly. And so there's an opportunity to build a relationship and to build trust with that person. And I think when you build that trust and that relationship, they're more likely to trust you in involving families. So I think there's a variety of ways to try to work with that, even if up front they're asking you not to talk with their families.
So Leslie, how have you dealt with this problem of privacy versus
right.
autonomy versus keeping
right.
the family involved? And
yeah. So the big thing I'd like to make about the point I'd like to make about HIPAA is that it is always
Explain what that term is.
HIPAA is the Health and,
Insurance Portability.
It's the law.
Act.
That's what we need to say.
It's the
That's all we
law
need to say.
that can keep the doctors from being able to tell the family members what's going on,
Right.
what the diagnosis is, and what the treatment is. But the law in no way limits what the family can say to the doctors right. and the other healthcare providers. So what we have found helpful is to try to engage, if you're presenting to the ER, engage at the front desk and say, gee, I really need to be able to fill in the doctor. After the patient has gotten back to a room, would you please ask the doctor to come see me and let me fill him in the waiting room out of the sight of the family member if they're really opposed to it at the time. Because otherwise it becomes a very confrontational thing, and if it can be kept separate and private, at least to have that one-way conversation, it can really help the family's relationship with the loved one as well. Because often they become very, very upset that you're wanting them to be admitted to the hospital and seeing that as a negative thing when really you're just trying to, many times, save their life.
What was your experience with the response of the providers of care when you
It varies, but most of the time, especially when you have a loved one that's been someplace repetitively, they come to know you and understand that you're looking out for their best interests. So I would say 90% of the time you get people that are pretty cooperative and will work with you on that.
Okay. And what about your experience?
I had somewhat the same experience. Went in cold, not knowing what was going on, and taking my daughter up to the hospital door, and they unlock and they let you in, and they went, okay, honey, you can go home now. And it was like, no, I can't go home now. So, and from that, I've evolved to the point to where I suggest that people, if they're going to see the doctor and they have information, remember how busy psychiatrists are, since we're 47th in the nation in psychiatrists per capita. Gotta throw those stats out there. Anyway, and so remember that they're busy. Write a bullet point, one-page summary of what you need to tell the doctor. Fax it to them ahead of time. Again, if you're in the ER, that's different. Then you need to ask to see. But if you have something scheduled, get that information out there. And again, we can say whatever we want to the doctor. He might not be able to say a thing to us. But there's also, in general, when people do this, and then you can have that general conversation, true. Not the particular one.
That's true.
What I'm talking about.
I do know.
Yeah, that is another opportunity. Yeah, and I can certainly receive information. I can receive information from a family member without even acknowledging that I'm providing care for that person. And so the person may know that they've come to me for care. They can call me. They can leave a message. I can return that message and take information without giving anything.
So it goes that far. If a family inquires, you can't even acknowledge that you've seen the patient.
It can. I mean, but, there are exceptions sort of written into the law for safety, and if the person is incapacitated. And another thing thing that we didn't bring up as well is that if the family is present as well. So if the person's in an inpatient setting, for instance, we can have a family meeting, and that provides an opportunity, I think, for more information sharing and more collaboration. In an outpatient setting, it could be coming in for the final 5 or 10 minutes of the appointment, or coming in, for every 3rd or 4th appointment, things like that.
So in my reading, in preparation for this conversation, I encountered many stories of families who described good relationships, good family relationships, and then disease comes and these relationships change. And again, you might think that if someone has an adolescent child, a young adult child who's in a car accident, the child is going to involve the parents in the treatment. But this kind of illness might isolate a person. Is that the case? Might it change the family dynamic there and make this more difficult? Yeah, you want to defer to the family members here?
We can all comment on this, and I think the answer is yes.
It becomes very strained, and it's a moving target. It's kind of like what he talked about. Even in a given day, it can be a moving target, and you have to learn as a family member to separate the illness and some of those behaviors from the person. And it's easy to say, and it's really hard to do day to day, depending upon what the situation is at the moment. But it's very difficult.
Mm-hmm. Where do people first make contact with a care provider in your experience? So we're talking here, we have a medical doctor and a psychiatrist, but there are other kinds of licensed professionals to which a person might turn for help. What is the range of resources and where a person might first become engaged? And then I want to talk a little bit about the people who are not specialists here but are in the medical field and might have a role in screening and referring patients. Okay? So maybe one of you?
Actually, the primary care doctors are getting much more involved in doing some mental health screenings. And I often, with my own doctor, have talked, and she's very interested in the class and taking the class or whatnot. But the training, people are just more interested in helping people kind of get treatment before things get really bad. So just from the very beginning, from your general practitioner, and then through, and then they can refer you out to someone. But there's nurse practitioners, and there's a lot of people that can actually help with the screening process as far as getting people help. But I would say your general practitioner is going to be the first place a lot of people go if they're not going to the ER.
Mm-hmm.
Well, where did, if I may ask, where did
we
you
went to the ER. I mean, Amy had
but
a
there was an
complete
emergency.
break. Yeah,
Okay.
she had a complete break, and it was ER, yeah.
We started with a pediatrician, who then referred on to child psychiatry.
Okay.
Mm-hmm.
And certainly primary care physicians are seeing a lot of folks with mental illnesses and even more serious illnesses. And so, for instance, antipsychotics are a treatment that we often reserve for more serious illnesses, and half of the antipsychotics prescribed in this country are prescribed by primary care physicians, family physicians, general internists, and not psychiatrists. So they are certainly seeing plenty of folks. There's a variety of ways people access the system. People may first seek treatment from a religious leader. They may see a teacher or a respected person in the community. They may come to the emergency room. They may see a family physician. They may present for a different problem altogether. And so sometimes they may present with one complaint, and then it turns out that the person's having significant anxiety or psychosis. I had a case where I was asked to curbside someone in the ER, and because I was there, I just went in and saw the person, and the curbside was for anxiety, and the person ended up actually having a first break of a psychotic disorder. And so sometimes someone's coming in with one complaint, and it turns out that there's something more going on. And so there's a variety of ways people access the system.
So can we inform our audience of what, if they think that this might be something happening in their families, what they should be looking for? What might be the threshold at which they begin to seek help?
Mm-hmm.
Okay, I'll start. He's looking at me. When you see unusual behaviors, things that are out of the norm, that persist, and you know your child, you know your family member, and generally it's a very close family member who is the one that takes that step to get care. So again, you look for something, ongoing problem or symptoms or behaviors or whatnot that are just totally out of the norm. and that you know something's wrong, and then that's when you have to do something. And I would start with my family practitioner, probably. I would have, had it not been such a serious break.
Okay.
I would say things like anger, withdrawal, depression, unreasonable reactions to everyday events, grade slipping.
Yeah, and I think if you see
Probably
these changes too, and they seem to be somewhat sustained, so it's not just, you know, one bad day or sort of one unusual period, but you're noticing a change that seems to be present day after day, I think that's sort of something worth bringing up and talking about. And if you have concerns, bringing it to the attention of a provider, such as a family physician or psychiatrist, if you have access to a provider, or psychologist. But I think if you're seeing that, I think it's very easy if you see some sort of changes in behavior to explain it away, like, oh, that person had this bad day at school, or this happened, or it's cloudy outside today, or whatever that is. But if you're seeing it sort of in a sustained manner, that suggests that those explanations may not be adequate and there may be more going on.
Especially with teenagers. Everyone expects them to act a little cranky.
Right. Yeah,
But if
in our
there's some-
case, we went through a stage of denial thinking this was teenage rebellion, but when it persisted and became more severe, that's when we had to go ahead and seek help with a pediatrician.
And I certainly encourage people not to be afraid to talk about it, not to be afraid to ask what's going on, how the person's feeling. One of the best definitions of stigma I've heard is distance, and I think oftentimes we put a distance between ourselves and this condition, whether it's with family members that are dealing with the condition, the people that are dealing with it. And one way to break down distance is with communication and presence. And so I encourage people, if they're seeing someone that they think is struggling or noticing changes in someone, not necessarily distancing themselves from that person, but actually approaching them, being with them, talking with them. If they don't want to talk, just being present with that person. So.
Now, in this extended circle of colleagues and neighbors that spoke to me in recent months, there were some happy and positive outcomes, and there were some that were not so happy. So what do we tell people who are coping about what's realistic to hope for? And as I called we're going to talk here for a few minutes about resources in our community, and I called and talked to people at the National Alliance for Mental Illness, which has an active chapter in Johnson County, and I was impressed by what I found there. And one of the messages was hope, but realistic hope. And another message was that the people I spoke with all talked about having to persist in finding the right kind of care. They didn't find the right care the first time, and some had disappointing experiences before they latched on to what worked for them. So maybe there's sort of two things I put on the table there is finding the right balance between hope and realism, and then this need to persist in finding the right kind of care provider and plan for treatment that's going to work for us. Who would like to jump in on that?
Yeah, that's a tough question. I mean, I think one piece I'd like to mention is that diagnosis isn't necessarily prognosis, and so one person with a diagnosis of schizophrenia may have a very different prognosis than another person with that same diagnosis. And so I think it's important that people maintain hope and not jump to the worst case scenario of the story that they heard on TV, or the worst case of that condition. There are many people with these that carry these diagnoses that are doing well, functioning well, contributing in great part to society. And so I think it's important to keep that perspective that the diagnosis itself isn't a prognosis. And that treatment helps, and that treatment can matter, and getting the right treatment is important. And so if the person isn't sort of getting back to their baseline, continuing to work toward that, and working closely with someone. And I really think the best sense you have of someone's prognosis is after they've been in treatment for an extended period, and seeing how they've been doing over that period of time, not necessarily at the initial diagnosis. So I would encourage people to maintain hope and to actively seek treatment. And we routinely get 2 quotes if you're going to replace the flooring in your house, if you're going to have, if you're going to get a car. I don't know many people that go buy the first car that they see in the lot, and I think it's worthwhile getting second opinions for mental health conditions, seeing more than one person, and getting educated as much as you can about whatever it is that your loved one is suffering with.
And please remember too, for people out there who are experiencing some of this, that my daughter was called the sickest of the sick. And now she has a job, she goes to school, and she has her own apartment, so it can end.
Absolutely.
So.
Say a few words about how you sustained yourself during this journey. We mentioned I mentioned one community resource. You might wish to tell us about others.
Well, NAMI has been very helpful doing the family-to-family program. I would highly recommend, because it not necessarily just the education that they provide, but having other people around that have the same experience, that get it, that it actually is very helpful and cathartic. For me, it's been compartmentalization. When I go to work, I focus on work. When I go to deal with my son, I deal with him and try not to have anything else interfere. And one day at a time, because it's a moving target, and what you have to work on one day may be completely different from what you have to work on the next day. And I would concur with what Jess was saying earlier about you have to keep fighting and finding the right answer, because for our son, when he began hearing voices, it took about 18 months for various drugs to be tried till the right one was found. And you just have to keep fighting and keep researching and keep proving the case.
But see, it was 18 months for her, it was 10 years for me. So it's getting better.
Okay.
And well, not for me, for my daughter. It was 10 years before we got the right medications.
Yeah.
So we're near the end of our half hour. I want to give you a chance to say a little bit about the teaching that you do, if you'd like to tell our audience.
Yeah, Mental Health First Aid, again, it's a basic course, and it's kind of a lesser step from family to family, and that's for people who are really in the mix of it, and really experiencing a family member with a serious illness. Where Mental Health First Aid is a course for everyone, the general public. I'd love to see more people who know someone who has a mental illness, who teach, who, whatever walk of life you're in where you deal with the public, you're going to run into people who are having mental health problems. 1 in 5 have a mental health diagnosis in any given year, and 1 in 17 have a serious mental illness. So that's a lot, folks. That's a lot.
Okay.
Yeah, these conditions are not rare.
No.
And you, I think, came to us as the kind of advocate for changing the law. We've only got a minute here for you to get in your
So I do think
point.
that it would be very helpful to have the law changed, that when somebody is actively in psychosis and clearly delusional,
Right.
that it be allowed that you would be able to have a conversation with the family members. That would be a very helpful change.
Okay. And I'm thinking for a moment here. But
And one caveat, I mean, I think so if someone's incapacitated, like they're unconscious, we know that we can work with family, but there's a gray area when it presents with psychosis, and I think it hasn't been super clearly articulated. Not everyone sort of is as comfortable in that gray, and so I think having it more clearly articulated would be helpful. And also I think it's different when family members are the direct caretaker for somebody.
Right.
You know, the person may be 18 or 19, but they're still living in the house, the family is feeding them, but yet somehow they're divorced from discussions of treatment, I think, can be problematic. But I encourage families and providers to persist in trying to work together, because like I said, someone might initially say that they don't want you to talk to their family, but that doesn't have to be the end of the conversation. In fact, that's just the beginning of the conversation.
Okay, I think we're near the end of our period, so I want to thank you, Jess and Leslie and Peggy, for joining us in this conversation. I learned a lot. I hope our audience did too. Thank you very much.